Neil, it's great to be with you today. Neil is a leader at Atropos Health, and let's talk some intros before we get into what Atropos does and some of your solution and some of the use cases.
Yeah, great to be with you, Sonia. My name's Neil Sangavi. I'm the president and head of product. Joined as part of the founding team at Atropos Health. Been with the company since basically the beginning. Joined very early as the company was getting spun out of the School of Medicine at Stanford, where two of our co-founders had been developing a solution called the Green Button, which I'm sure we'll talk more about. I got fascinated with the idea after I met them and started helping them out during the pandemic, and then joined full time once I could send my kids back to daycare after the pandemic daycare closures ended.
That sounds great. And how long has that been? How long has the company been in?
Almost 4 years now. I've been working with them a little bit over 4 years, and the company really kind of got going with full-time employees January 1st, 21.
Fantastic. So I always like to start with what problems you and your co-founders were looking to solve as you looked at the healthcare space, knowing there's a lot of different problems that could be solved. What problems did you focus on? Why were they important? And why are they still important now?
Yeah, so at the core of the company, what we're focused on is what we call the evidence gap. It's basically what exists in healthcare, in medicine, where there just isn't enough evidence for all the different scenarios that clinicians find themselves in. So think about the highest value evidence, the evidence that people try to find for every scenario. It's these kind of multiple randomized control trials that with a meta-analysis on top of them. That's what you're trying to base all your clinical decisions on. However, very few scenarios in clinical medicine actually have that level of evidence available to them for those scenarios, right? So there are many types of patients. Those patients are typically not included in the clinical trials that are being conducted. And so what we're broadly kind of focused on is how do we close the gap between there are all these great data sets out there. There are all these great studies out there. How do we bring everything together into a kind of a cohesive format for physicians to be able to use, life sciences companies to be able to use to kind of drive the healthcare industry forward? And that kind of gap in evidence, we're trying to close it with generating new evidence and then also bringing kind of the existing evidence to the table and summarizing that and kind of combination. Those two things can really kind of help close that gap very, very quickly. And then that leads to better decision making at the point of care, where you have physicians using that new evidence or that synthesized evidence to drive their decision making.
And so that leads to greater clinical outcomes, better efficiency. What are the big goals that a health system usually goes after when they look to a company like yourself?
Yeah, so there are a bunch of KPIs, and it kind of depends on who we're talking to first at the organization. It kind of that varies, and that kind of determines who's their kind of key stakeholders and key performance indicators that they're most interested in. I'll hit a few. One is when we get to a health system and we're introduced through their pharmacy department. So inpatient pharmacy directors, chief pharmacy officers, sometimes the inpatient medical directors or kind of head of hospitalist medicine. Those types of folks are typically tasked with reining in what's called care variation. So lots of different decisions being made for the same types of patients tends to lead to variable outcomes, and we are not sometimes that variation is warranted, sometimes it's not warranted. And so these teams of pharmacists and physicians sometimes get together in these care variation reduction groups, and they work together to identify those areas of unwarranted variation and use tools like ours to be able to root those out, identify those, find those physicians that are kind of practicing suboptimally, and then use the evidence that we generate to help kind of get them back onto the track that they're expecting. So that's an example of one, and I'll give one other example. In academic medical centers, there are usually a few dozen departments. All of those department chairs are constantly jockeying for positioning in the academic medical center, and and they're always competing against other academic medical centers for the kind of the best and brightest talent. And so one of the key indicators for a kind of a high performing department is how quickly can you get things from I have an idea for a study to I have a manuscript that's publication ready for a study. And so obviously, as you're generating new evidence through a service like ours, we could dramatically accelerate that type of pipeline. So those are two kind of completely different kind of use cases, different types of users. And a lot of times there's actually a really great overlap between those, where at an academic medical center, you still have chief pharmacy officers. And so you can kind of see a combination of both of those use cases being kind of satisfied at the same time.
Very helpful to understand sort of different avenues of entry. So tell us now specifically about the solution. What does it do? How is it different? Give us some specifics.
Yeah, sure. So there are a handful of solutions that we've developed, and I'll kind of talk through them in terms of kind of the different user experiences that we have. So the first one is what we call Alexandria. That's our library of content that we've generated over time. We've done in the first 4 years, we've done about 4,000 new studies. So we've generated 4,000 new real-world evidence studies that are available in our library that are just that were just generated based off of questions that users have asked us, and we've generated another 8,000 to 10,000 studies that we've developed internally, and we've said, hey, these are interesting questions, they should be answered. We shouldn't have to wait for a physician to ask us the question. We have a bunch of doctors internally. Let's generate that content. And so the library where that's constantly growing every day, the place where all of those studies go, that's what we call Alexandria. We make those studies available to various types of users. So even if they're not asking new questions, they should be able to access the content that we're generating as a reference source for decisions that they're trying to make every day. So that's kind of the lowest level of a kind of use case. The next layer up from there, go ahead.
Access it in their workflow? Where and how do they access it?
Yeah, so we have a series of partnerships with different organizations. So obviously they can come to our application from Atropos Health, atroposhealth.com. You can launch directly into our application there to access Alexandria. We also have our content embedded in a variety of different sources. We have partnerships with companies like Arcadia, which is a value-based care platform, and other companies like that. So we can start to share that content through these different workflow tools that kind of meet those providers where they are in the workflow. So that's an example of one. And again, we have other partnerships as well.
So level one is content creation of evidence and studies that can be accessed through some of these other partnerships and
existing content. So then the next 3 levels are all about creating new content.
Okay, let's go there.
So the green button service, which I alluded to earlier, originally developed at Stanford. The concept was, what if we could set up a consultation service very similar to the way that hospitalists might consult with a cardiologist? What if we could consult with the data that exists in our data warehouse? And so Dr. Nigam Shah, who's one of our co-founders at Stanford, set up a service along with our other co-founder, Saurabh Gombar, where physicians would ask them questions, and then their team would run a just-in-time real-world evidence study on the Stanford EHR data. And it normally took between 4 and 7 days to run those studies at the time at Stanford. Now we have a 2-day SLA for those. So any question that comes in within 2 days, 2 business days, we'll send you back a publication grade study answering that question. And again, that's deployed at a number of health systems. And that's where we're getting our questions from our physician users, researcher users, and those questions are answered through the green button. It has a physician in the loop on our side. So there is a human that receives the question. They use our technology to develop a study, and then they send that back to the requester. So that's kind of the second tier. That's how we generate new questions.
And just to clarify, that is, you said run on the health systems EHR, or is it a broader data set that you run?
Yeah, so both. So we have access in many cases to our customer's own data asset. And there are a lot of situations where you want a local answer to a question because you want to know, okay, on my population specifically, what is the answer to this question? Now, the next question that you often might want to ask is, okay, and how does that compare to everybody else? And so we have third-party data sets as well that are kind of usable for benchmarking. We have a variety of different data sets. We call that the Atropos Evidence Network. These are kind of a network of data sets that are available and shareable across sites.
And I imagine some of that data answering and creation of that content accelerates with the Gen AI capabilities. I'm sure
Yep.
you're exploring that. Yeah.
Yep. So that's number three.
Okay,
Kind of
great.
perfect segue. Yeah. So we have a new product that we just launched last week at the health conference called Chat RWD,
Okay.
and that product basically takes all the things that the human in the loop was doing on the green button and looks to
Mm,
automate each of those pieces. And combining it with, again, since we've run all these kind of over 10,000 studies at this point, our medical team has been writing definitions of like, how do we define diabetes? How do we define heart failure in EHR data? So those definitions, we call those clinical definitions in our clinical definitions library. How do those definitions get kind of assigned to a question that's being asked? And so that's what we've spent the last year figuring out how we can use generative AI capabilities to do that. And what we built was this application called ChatRWD that has a very similar, it's integrated in the same place that you would ask a green button question. But if you feel comfortable generating the study on your own, it will take you through a series of prompts that will help you turn your single free text question of, is Keytruda better than Opdivo for treating non-small cell lung cancer, and translate that into a full query that can be run against an EHR data set and then summarized into a real world evidence study. So that application, again, we just released it after a year of in beta and building and iterating. And we're super excited about that over the next year. And we actually think that we'll have more users on ChatRWD by the end of next year than we have on Green Button. So there's a lot of growth potential on that one.
that is really exciting. And, Avia has been involved with a lot of different AI initiatives, bringing health systems in our network together. And usually there's so much resistance around clinical use cases, but it sounds like you're getting good traction with something like this because it is still providing decision-making support, but not actually fully embedded in the
Right.
clinical decision pathway. So there's like less risk there. Is that the way to think about it?
Well, two things. One is the user is mediating every step of the
That's
process. So anytime something goes into a generative AI tool and it comes back, the user sees the output and then has opportunity to validate it, say reject it, say I don't like this definition, I want something else. And so it's a user mediated, expert mediated flow through multiple generative AI LLM calls throughout the flow. So you can kind of see you have kind of multiple opportunities to course correct at any step along the way. And yeah, to your point, it's not making any decisions for anyone, right? At the end of it, we're generating a study. That study can be used as another piece of information for that provider to use to make their choices. But we're not ever making a treatment recommendation, for example, in the clinical workflow.
got it. And that makes sense. Tell us about uh, your differentiator for your solution. Are
Yeah.
there other solutions you see similar to yourself that are commonly being used? Or do you believe you're first in this space, and what makes you different?
Yeah, I would say the key differentiator that we have is speed.
Mm,
Observational research has been done for decades on electronic health records and claims data. There are large teams at academic medical centers and life sciences companies that are focused on buying real world data and generating real world evidence from that data. However, the average time from question to answer in real world data is 3 to 6 months. And
wow.
we have a 2-day SLA on our manual
Mm,
service, and it takes just a few minutes in ChatRWD to go from question to answer. So the by far kind of the most important differentiator that we have is speed, and obviously kind of just below that is speed without sacrificing quality, right? So the major trade-off that often is the case in all of technology is, okay, yeah, you can go fast or you can do it well, but it's very rare to be able to do both. And we have over 50 publications in peer-reviewed journals coming from directly our evidence sources. So we've kind of shown through the work that we've done over the last few years that you can actually achieve the speeds that we're talking about without sacrificing quality. And then to kind of answer the last part of your question, which is kind of, are other folks doing this? Yeah, absolutely. There are lots of companies doing real world evidence. There are lots of companies that sell real world data. It's just the combination of kind of the technology that we've built and the data that we have access to and the evidence network that is unparalleled in terms of kind of scope of data and speed with which we can deliver insight.
and it's scope of data, speed, and speed with quality. You had mentioned earlier that you have clinicians who are looking at some of the data, checking it. Tell us a little bit about that capability and what does that look like for you?
Yeah, so in both Green Button and Chat RWD, we have the option. In Green Button, it's required. There's always going to be a physician in the loop for Green Button. What's happening is a user submits the question, it lands in a physician's queue on our team, and that physician will review the question, ask any follow-ups back to the requester, and say, okay, how do I translate this question into the appropriate study design? Is this a causal inference question? Is this just a descriptive question? Select the right template, fill out the template, create all the definitions that I would need to answer that question. So again, the diabetes definition, the heart failure definition, if we already have one, great, we'll pull it off the shelf in the library and insert it directly into the template. If not, we'll convene a small group and create a new definition for that specific case. And then when that's ready to go, we'll run that against the selected EHR or claims data set. And then that final product will be reviewed by a medical director on our team. So really, in effect, on Green Button, 2 physicians are touching every single one of our reports that we send back. And then that report gets sent back to the requester through our applications, where they would then be able to review it, ask follow-up questions. Again, it's very common to get a returned report from us and then ask 7 to 10 follow-up questions right after that, and kind of in series, and kind of doing sensitivity analyses and changing the cohort definitions and all those kinds of things.
Very helpful. You've already talked about the KPIs and the goals and the impact that a solution like yourself can have. As we get to our close of our time here, anything else you'd like to share? By the way, congratulations on the release last week. What else would you like to share with anyone listening?
Yeah, number one is what you just mentioned. ChatRWD was just launched last week at Health. Go to atroposhealth.com and check it out. You can sign up, create a free account, and try out 5 free chats on ChatRWD, especially for health system users. It's already kind of set up for all health system customers that are out there.
Chats. Okay.
Yep, 5 free chats. And then the second thing I'll just hint at is we're getting ready to announce a series of partnerships in oncology specifically. So oncology data is a kind of separate category of data. So I talked about claims and EHR data. Obviously, oncology data is related to EHR data, but in particular, there are very specific biomarkers and other elements of that are often removed from the EHR data sets that are traditionally used for real world evidence. And there's a kind of a narrower set of data that are out, the sets of data that are out there that are focused specifically on curating all of those oncology records and getting the staging and the biomarkers in there. And so we have a series of partnerships that we've been building towards, and we'll be announcing that here before the end of the year.
Fantastic. Very exciting. We have a number of cancer centers within AVIA's network as well. So I'm sure they'll be listening to this and eager to learn more.
Yeah,
Neil,
and if people need more information about that, they can get in touch through our website as well.
Fantastic. So go to atroposhealth.com or come to AVIA Marketplace to learn more. Neil, thank you for going through all of this. Congratulations again on all your work and success. And thanks for your time.
Great. Appreciate it. Thank you, Sana.